Neurogenic OH is a subtype of OH that is due to dysfunction of the autonomic nervous system and not solely due to environmental triggers. Neurogenic OH is due to lesions involving the central or peripheral autonomic nerves. So as I said, vasovagal syncope is the most common form of reflex syncope mediated by the vasovagal reflex. It may occur with an upright posture, either prolonged standing or sitting, or with exposure to emotional stress or pain. It is associated with vasodepressor hypotension or inappropriate bradycardia and often followed by fatigue and often preceded by identifiable triggers or by characteristic prodrome. Carotid sinus syndrome is defined when syncope occurs in the presence of carotid sinus hypersensitivity. It is when a pause of 3 seconds and more or a decrease of systolic pressure of more than 50 mmHg upon stimulation of the carotid sinus. So when we encounter suspected syncopation, the initial physical examination and ECG before we do the risk assessment for the evaluation and treatment. So proper stereotactic, we must ask about the first age precipitating factors, such as the warm or crowded area, pain, emotional distress or fear. It might direct us to the cause of the syncope, which is the cause of neurally mediated or orthostatic activities such as cough or laugh, unexplained fall, or shaking might direct us to the carotid sinus hypersensitivity. Exertion or shortly after exertion and prolonged sitting or standing up. So the other history we should take is prodromal symptoms, just like headache or dizziness, might direct us to the hypertension. Severe headache might raise the possibility of intracranial bleed, SEH, focal neurologic deficit, chest pain, SOB, dyspnea, palpitations might direct us to the cardiac syncope. Low back pain or abdominal pain. The possibility of ruptured abdominal aortic aneurysm that causes the hemorrhage. So, we should ask is the duration of the prodrome, which is helpful in differentiating neurally mediated syncope from cardiac syncope, position before syncope, and supine position, or there is sudden change in the posture, frequency of syncope, is it the first time or recurrent syncope, and medication use. Medication such as antiarrhythmic, anti-emetic, family history of heart disease, or cardiac death. Then we proceed with physical examination. First, general examination with vital status, hydration status, complexion, blood sugar. Examination, look for if there is any melena or any evidence of loss, and check from head to toe for signs of trauma. As we should pay attention to the heart rate and rhythm as well as gallops or rubs that would indicate the presence of basic neurological examination. We do the examination and cranial nerve examination. Vital signs or pressure, look for the SBPs less than 90 or decrease in the diastolic blood pressure more than 10. Reflex tachycardia may suggest hypovolemia and distance may suggest autonomic dysfunction. This is among the ECG features that might have in the cardiac patient. Typical structural heart disease or CAD. You might see sinus bradycardia, complete MV block or maybe secondary MV block, pre-excited QRS complex, left block, VT or paroxysmal SV, long or short QT intervals, Brugada syndrome, which have right bundle branch block pattern with ST elevation in the anterior precordial leg. Also, malfunction of the pacemaker or implantable cardioverter defibrillator. So, investigation in patients with syncope is serum or urine pregnancy test for age and random blood glucose. And from our initial evaluation, we might consider FBC to look for the hematocrit, RPF if the patient in altered mental status, if the initial evaluation directs us to the cardiac cause, BNP but it is not easily available in our setting, but it can from the non-cardiac cause. Stool frequent occur. Our clinical judgment, we may refer patient for inpatient evaluation, monitor of stress test, aortic ultrasound, echo, DEG. So, disintegrate, we do disintegrate if suspected first seizure, secondary trauma sustained during the syncopal episode, which is trauma of the clavicle, suspected TIA or stroke, if there is neurological or altered conscious state or confusion, each more than 6, sudden onset of headache, and if patients on warfarin. After our initial evaluation, we do the risk assessment for providing the treatment and preventing long-term morbidity. The short-term prognosis of patients presenting with syncope, the cause of syncope, and the acute reversibility of the underlying. Long-term prognosis is related to the effectiveness of therapy and of the underlying disease. So there are a few encounter patient with syncope, but the most common use is San Francisco syncope. The sensitivity is about 98%. It predicts the serious outcome at 7 days. The criteria is history of congestive heart failure, hematocrit less than 30, arrhythmia changes in ECG, SBP less than 90, and but we do not use the San Francisco if there is persistent altered mental status or new neurological deficit, alcohol or drug-related loss of consciousness, definite seizure of consciousness due to head trauma. So this is another score for syncope, EGSYS score. It doesn't give them San Francisco, but it is useful to predict the cardiac syncope. The criteria include palpitations preceding syncope, heart disease or abnormality, syncope during effort or while supine, precipitating ovarian factors or both, and autonomic prodromes. If the EGSYS score is less than 3, we might discharge the patient. Proper follow-up as our patient. But if there is or more, we have to admit the patient for cardiac and cardiac arrest. This is the rules that we use to predict adverse events in the syncope patient. Policy used for the period of 12 months actually of mortality. Criteria include cardiovascular history, ECG abnormality, no prodrome, and age more than 65 years. Boston and Rose actually used to predict the major adverse outcome at 30 days. So after our initial evaluation, do we know the cause of syncope? And if we do know the cause of the syncope, is it dangerous, such as the cardiac cause or neurologic or hemorrhage? If the possible cause is then we have to admit the patient for appropriate management. But if the possible cause include the reflex syncope such as vasovagal, so discharge the patient, give the reassurance, patient education on the diagnosis, give advice for physical counter-pressure maneuvers such as positioning, contraction or squatting. Middle grade is reasonable BBS with no history of hypertension, heart hypertension. So for cardiac sinus actually for the team for the permanent cardiac PC. In the situational we could advise patient to avoid or eliminate the therapy factors or increase fluid and salt consumption and reduction or of intensive drugs. In orthostatic hypertension, treatment is usually often address lifestyle changes, ask patient to drink enough water, take the head of bed, avoid crossing leg and standing up slowly. And if it caused by medication, you can change the dose or stopping the medication. So if you do not have the clear cause of syncope based on our risk stratification, if the we should admit the patient for further evaluation and for monitoring. If it's low risk, we can reassess the patient again and ensure patient is asymptomatic. If it's okay, then we can discharge with appropriate follow-up as outpatient. So this is the discharge criteria for Syncope. Patients can usually be discharged if they do not have significant clinical risk factors, including abnormal ECG, CVS risk factors, initial hypotension, and initial shortness of breath. Also, if observation and clinical findings are normal, medications reviewed, and safe for environment, especially in the elderly. So this is my reference. Thank you.
Okay, Assalamualaikum. Good morning. Thank you, Aisyah, for that presentation. So, for my presentation, focus more on the risk stratification in Syncope. So, as you know, Syncope accounts for about 1 to 3% of ED presentations, the most common being the reflex syncope, hypotension, and lastly, cardiac syncope. So, the role of risk stratification, it helps to estimate the prognosis whereby you can classify as low or high risk patients. Also establishes urgency for additional tests and specialist evaluation. Also, it helps to reduce unnecessary admissions, whereby it will be cost effective. So, this is the algorithm that I got from the Society of Cardiology guideline, which was released in 2018. So, as you can see, once you have made the admission of syncope, followed by the initial syncope evaluation. However, after your syncope evaluation, you cannot come to a diagnosis. This is where your stratification comes in. So from the risk stratification, you can divide it into high risk or low risk. So from the 2018 guidelines, they divided it into low risk and high risk criteria based on history, physical examination, and also ECG findings. So as you can see, they have quite thoroughly. This is from the history itself, and then from past medical history, physical examination, and ECG findings. So once we have gone through of the criteria, then you can divide the patient whether the patient has only low risk features, any high risk features, or neither high nor low risk. So if the patient only has low risk features, the patient can be discharged directly. Then if patient has high risk features, can either be admitted to the ED observation, or some hospitals, they might have the syncope observational unit. And then from then on, you can decide whether it needs definite admission or not. So there are risk stratification scores for syncope. I think Aisyah has mentioned most of them, but I'm just gonna go through one by one. So actually, these are the most common ones. 6. First one, axial risk score, released in 2003. The most that we are using is San Francisco syncope rule on 2004, followed by Boston syncope in 2007, the axis score 2008, the Rose study in 2000, and the latest one is actually the Canadian syncope risk rule, which was released in 2016. So based on this article, the American Family Physician, which was released in 2017, they actually compared all 6 criteria. So from this very nice table, they have actually divided all 6 studies and compared it based on the formation of the study, the predictor variables, outcome measured, score results, and validation. So let's see one by one. From here, the first 2 scores, the oldest one being the asset. As you can see, actually predicts long-term risk compared to the San Francisco group, whereby the SL score predicts mortality at 1 year, whereas the San Francisco syncope rule predicts serious events at 7 days, such as MI, PE, CVA, arrhythmias, etc., etc. And as you can also see, the predictor variables are pretty straightforward and easy to sort of predict from your history. So there's abnormal ECG findings, absence of prognosis, age more than 65, history of cardiac disease. Then it's also the syncope rule with the addition of shortness of breath and maybe less than 90. From the internal and also validation studies, the sensitivity for both studies are quite high. However, the specificity of the San Francisco skin rule is higher compared to the SOV score. So because one is a long risk and the other a short term, sometimes they combine these two. Once patient is stable and admitted, then you can use the SOV score, whereby it's better to use the San Francisco syncope rule. Okay, we have the axis score, row study, and also the Canadian syncope risk score. The axis score in 2008 actually it predicts specifically from cardiac causes. So I'm going to talk about more about the Canadian syncope since these are the more recent ones. So as you can see, the outcome measured, the Canadian syncope risk score, row study, and also the axis score is long-term. Sorry, not long-term. The axis score is long-term, whereby the row and the Canadian syncope rule is short-term risk calculation. The predictor variables compared to the older score, as you can see, they are more detailed now. They even define the abnormal ECG criteria that they want to see. So if you can see in the row study, ECG showing 2 waves except in the 3, the Canadian risk score, abnormal QRS axis, QRS duration, and corrected T interval. So in terms of the validation study, the ROSE study in 2010 shows sensitivity and specificity compared to the others, and the syncope risk score is quite new in 2016, so there are not a lot of validation studies available. Okay, so from all of this, so which score do you think that we can use? Okay, so actually, because the San Francisco syncope rule, it has been available since 2004. There are a lot more validation studies available, thereby it is the most recommended because of the validation. However, it should be emphasized that no clinical decision tool should be broadly applied to every patient to be used without looking at the entire clinical picture. So you can use these tools to guide you in your management in ED, which not your management. Okay, thank you. Any questions?
Thank you, Aisyah Syazmin. Okay, so for patients with syncope, actually for SBD doctors and our primary goal is to identify those at high risk. To identify those at high risk, and if you're not able to for the patients in the patient, it doesn't mean that you have not adequately patient, because up to 50% of patients, no clinical cost can be found for their. So your primary goal as an ED doctor is to identify those at high risk. Okay, this San Francisco, it identifies those at low risk, which low risk patients who not benefit from aggressive workup ataupun hospitalization. Okay, but at the end of the day, clinical judgment is more important. So if you have significant concern about the patient, so even if the patient is deemed low risk by the score, you should still expect no workup. Okay, and number 4, it will be of issues that Aisyah presented and not be given the San Francisco rule. Alright. Okay, so all these 4 options are given the San Francisco. I agree with Dr. Aisyah. What about the high risk patients? Anyone can remember this if there is for high risk patients?
that you not think of discharging very easily. So you have anyone anything else? Yeah. For the ages. History, okay, for the age group. That's very important. Syncope is very when they present to us as the that they have brief LOC. So when they come to us, they are talking to you, you're well, they may not have any symptoms. This kind of cases will be triage degree usually. So you have to pick up all those warning signs that can be easily missed, especially when they have life-threatening conditions. So what causes, you can see Aisyah has presented, we've got a lot of causes of syncope. So the head, the heart, the vessels, for me, I didn't like that. So head can be hypoxia, seizures, the brain, and then the heart. There's so many ECG findings that to make sure that you have already ruled out. So ECG is very important during patient that had syncope. So even in green, you should actually ask for an ECG because it does so many things. And then the vessels are very common, artery dissections, all those kind of things.
If other patients do not forget to look for associated injuries, like syncope, so for associated injuries. Also remember, patients with nasal bleeding symptoms and chronic for injuries, you can have urinary incontinence. It's very important for you to get vaginal syncope and also seizure. How do you differentiate? What's the difference? Thank you.
Pada seizure dia akan abruptly dia punya proses fikir balik. Usually for seizure, essentially depend on type of seizure. Because sometimes whereby they just transient loss of consciousness, ataupun without interpretation of polyclonic seizure. It is very difficult, but if it's clear-cut seizure, for example, those patient has those type of seizure yang DTC ataupun yang impact consciousness with motor movement, they have a rate of loss of consciousness quickly. So it's clear to differentiate. Jadi satu kalau additional I Syncope, it's actually manifestations of allergic. So we need to take proper days. Sometimes we might miss the causes of the symptoms. So this celebration we need to take one part of the celebration, so we need to take primary and seizure.
One of the provide picture For seizure, it occurs before the LOC. The microlesion occurs after the LOC. Another difference is lateral time binding. It sensitivity for seizure compared to syncope, and the dominance is seizure but not syncope.
Business is very important in this. They cannot provide you what is the things that happen. If they it's not severe, so not enough. You can ask regarding the what the patient needs, changing position and that more of the postural Singapore type things. Having the myotonic here or become unconscious to wake sitting position. So it is more likely severe or syncope. So all these things are to gather information. Then before during the event and after the event. If the patient after when they wake up body aching and all that, it points towards more severe. If no weakness, no weakness. So if ask only the patient at times muscle ache and all that, likely got more likely got from the direction. Kalau patient can send the duration is, for example, let's say I'm working in another factory, and I say, I loss of consciousness. I bring then over here, only we get consciousness. So the diagnosis become a bit lower because the vital emission after a rate transient. So the hypotension cannot last so long, it only for a while, then the mechanism compensates. So it few minutes. If for long, the consciousness period slightly not so much of syncope. The San Francisco score is like what the presenter was saying, it's only like you have rule out other things. That means you don't know what the diagnosis are for unidentified cognitive use. You don't straight away differential diagnosis is straight away apply. So the one is wrong. This is just for safe discharge only. So you apply. The reason all the criteria is behaviors, underlying heart failure, hematocrit low, and all that. That is actually to pick up dangerous condition, maybe it's a cardiac problem. Most of the syncope accident discharge is no complication. The cardiac syncope that we want to pick up. So you see the criteria pertaining to the cardiac.
Anyone has any questions? Any questions? To wrap up the whole presentation today.
I think Syncope is sort of a simple presentation, but I've been working in ED for 5 years. Then after Syncope, you look at cut to oh God, it can be anything. And then I think we are biased to think that, especially those younger patients, probably not inclusive because it's so legal, but you have to keep in mind that they can still come with cardiac causes, such as Bugada, some other structural heart disease, So I think the takeaway message is that, especially if you have been working for quite some time, just have to keep our minds open, our diagnosis brought up. Oh yeah, female patients. Yeah.